I usually talk about head and neck cancer, but I thought I'd talk today about obstructive sleep apnea. Now, there's no disclosures. My aim is to discuss the evidence for surgical treatment of obstructive sleep apnea. A few definitions. Apnea, there's no airflow for 10 seconds. Obstructive apnea is when there's no airflow for 10 seconds despite respiratory effort. Hypopnea is a reduction of airflow by 50% or more for 10 seconds. And the apnea-hypopnea index is simply the number of apneas and hypopneas per hour. Let's define obstructive sleep apnea. In children, it's when the apnea-hypopnea index is 1 or greater, and in adults, it's when it's 5 or greater. And it can be subdivided into mild, moderate, and severe, as outlined on this slide. How prevalent is it? These are some figures I found. I'm not sure if I believe the figures. I think as the obesity epidemic increases, the number of patients with obstructive sleep apnea also increases. This is what I was taught at medical school. We had this really nice little mnemonic, F.H. Shrewd. I don't know if any of you remember that. These are the risk factors for cardiovascular disease: family history, smoking, hypertension, raised lipids, lack of exercise, obesity, diabetes. We can now put obstructive sleep apnea on that list. That goes to show that knowledge does change over about 30 odd years. So obstructive sleep apnea is associated with accidents, and motor vehicle accidents in particular. Blood pressure, pulmonary hypertension, stroke, and myocardial infarction. So why treat it? Is it just to keep the partner happy? Well, patients will feel better when their obstructive sleep apnea is treated. It's easier for them to lose weight once their obstructive sleep apnea is treated. Become more productive. But more importantly, studies have shown that if obstructive sleep apnea is treated, then there's a decrease rate in those patients when compared to patients with untreated obstructive sleep apnea. Treatment options. 3. There's only 3 treatment options: lifestyle factors, appliances, and surgery. But within each of those categories, there are multiple treatments. Some of the appliances. CPAP is the mainstay of treatment for obstructive sleep apnea. Mandibular advancement splints and other various devices. So let's talk about about CPAP. Well, it's a highly effective treatment if tolerated. And some studies show compliance of up to 85% of patients can comply with CPAP. But that's really pushing it. That's with cognitive therapy and the like. It's really important to address those issues which are problematic for the patient to try and increase compliance. Even when they're compliant, they don't generally use it all night long. Some do, but most don't. So you look at this Swedish Council of Health Technology review, and this is not only Sweden, but it was all the Scandinavian countries, Norway, Denmark, and Finland. 70% still use the CPAP device after 1 to 4 years. Put it the other way around, 30% are not using it. And the mean use is for 5.3 hours. How many of us in the room are happy to have 5.3 hours of sleep per night? Maybe more like 7.5 and you start feeling good. So for 2 hours or more, you still have obstructive sleep apnea. So you won't read this out of any textbook, you won't read this out of any journal, because I made this up. But let's just look at this mathematical model. If your AHI is 100 and you sleep, say, for 8 hours and you use the CPAP machine for 6 hours, that means that for 2 hours, you still have an AHI of 100. You divide that by 8 and you get that number 25. So I called that the corrected new AHI. Well, pardon me, if you've still got an averaged AHI of 25, you've still got obstructive sleep apnea. And you can fiddle around with these numbers, the AHI, and you can fiddle around with the number of hours of sleep and the number of hours of CPAP use, and those are the figures that you're getting. So how effective is CPAP? Well, it can be very, very effective for an individual. But let's look at a population. So if you have 100 patients with an AHI of 30, you put them on CPAP, 30 patients will still have an AHI of 30 because only 70% tolerate it. 70 patients will use CPAP for an average of 5.3 hours. We know that roughly from that Swedish review. You assume that you would like to sleep for 7.5 hours per night, so the corrected AHI for the 70 patients using CPAP is actually 8.8. And for the whole 100 patients, the average AHI is 15. So the population still has some degree of obstructive sleep apnea. What about surgery? Well, in the pediatric population, it's a good treatment. And there are multiple studies, these are just two, that shows a cure rate of between 80 and 85%. Again, not everyone. What about for adults? Well, there's a whole bunch of different operations. Actually, when you think about the term obstructive sleep apnea, it's a little bit like heart failure. Heart failure secondary to what? Secondary to ischemic heart disease, secondary to valvular disease, secondary to a cardiomyopathy. So not surprising, because there are multiple different potential sites of airway collapse, there are multiple different operations. And sometimes, you know, the problem is to a large extent obesity. Tracheostomy treats obstructive sleep apnea, but it's a hard operation to sell. But in some patients, that may be a good option if they've got severe pulmonary hypertension and the like, and it's progressive. Hypoglossal nerve stimulation is a new kid on the block. It's actually not that new. It's been toyed with for many years, but it's certainly in the States and now in Australia, and I assume at some stage in New Zealand, hypoglossal nerve stimulation. The way that works is stimulates some of the fibers of the tongue muscles, and the tongue comes forward and that opens up the airway. Dr. Stuart McKay is a ENT surgeon in Australia, and he's published on this modification of a UPPP expansion, spharyngoplasty, palatoplasty. And you see here the uvula is smaller, but there's a lot of mucosa that's not affected. And so the risk of stenosis is lower. And here are his results, not my results, his results, in an AHI pre-op and post-op, and this is the interquartile range, so this is from the 25th to the 75th percentile. So the AHI dropped from 23 down to 5, and this is the Epworth sleepiness scale from 10 to 5. So it is a useful operation in selected individuals. Again, choose well. This is Michael Friedman's work from Chicago, and this is looking at tonsil size, 0, no tonsils are visible, 4, the great big tonsils, and this is the tongue or palate. Oh, sorry, next slide is the tongue or palate. Here we have the 1 and 2 stages where you can see most of the oropharynx, and 3 and 4 you can see diddly squat. And here he has his staging system. So I want you to look carefully at this, because he's 4 stages, and he's using this to predict successful surgery, so how to select patients. And so he's taking palate position, tonsil size, and BMI. And then once you're over a BMI of 40, the results drop off considerably. What's not on this list? The AHI is not on that list. So when I was taught at surgical school, sorry guys, when I was taught at surgical school, they said surgery for cases with mild to moderate. But that's not true. You can have severe obstructive sleep apnea, be in this category here, and have an 80% chance of being cured. You can be in that category there and have a 75% chance of being cured, and you can be in that category there and have about a 40% chance. So this is looking at the AHI pre-op and post-op for the various stages. So in conclusion, CPAP compliance is a big issue. Medline search CPAP, 10,000 articles. Medline search compliance, join the two together. There's over 1,000 papers, 1,500 papers on CPAP compliance. It is a big issue. Surgical candidates. Best surgical candidates are those with a BMI of less than 40, and that surgical results are independent of the severity of obstructive sleep apnea. Thank you.